Welcome! This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at www.nhadaca.org within our webinar library. After completing this webinar, please complete the quiz and evaluation if you're interested in receiving a certificate. You can find the quiz and evaluation on our website next to the Watch Now button you selected to view this webinar on our website. If you are a member of NADC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You will receive a certificate worth 1 CE once you've completed and passed the quiz and paid for the webinar if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this one-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Other Drug Use Professionals, as well as NBCC. If you have any trouble viewing the webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to training@nhadaca.org. Now let's begin the one-hour webinar on core function number 8, crisis intervention. My name is Kelly Ludke, and currently I am the program coordinator at NHTI, Concord's Community College, in the Addiction Counseling Program. I also teach in the Human Service Department as well. I have my Master's of Education in Counseling, a certified advanced degree in counseling, and I'm also a New Hampshire master level LADC in the state of New Hampshire. I earned my bachelor's degree in psychology from the University of New Hampshire, Durham, and I also went on at UNH to get my master's in education counseling. My certified advanced degree in counseling is from Rivier University. My background includes a variety of different substance treatment, and that would be from a clinician to an administrator. Most recently, I was clinical director and COO of a major facility in New Hampshire, and currently I'm just in education right now. I'm the past president of the organization NADC, and most currently a licensing board member for the Alcohol and Drug Use Professionals. If you have any questions about the material we talk about today, please feel free to email me at kludke@ccsnh.edu. I'm currently, during the summer, I work from home, so calling me won't really work, but when I get back to campus in the fall, you can certainly give me a call at my direct office number there. I think I'd also like to say, too, that at NHTI, I do teach a course on the 12 core functions. It's an 8-week online course. So if you're interested or you need it for licensure or just interested in it towards your CRSW, then please, give me a call or email me, and I can connect you with the information for this 12 core functions class I teach. So let's jump right into it. I'm going to talk a little bit. I like to tell a lot of stories in my teaching because I think it really makes things practical. It takes things from theory to practice. And most recently, like within the past month, I was supervising a person towards licensure, and we started to talk about core function 8. And she works at a substance use facility. And when we started to talk about crisis intervention, she said, well, I don't know that I actually use crisis intervention. And I kind of just looked at her like, what do you mean? Like explain that. And she said, well, I've never had clients that are suicidal. And so it dawned on me that people have such a variety of definitions around what crisis is, what a crisis intervention looks like. And it was a great opportunity in that moment of supervision to say, somebody doesn't have to be suicidal for somebody to think that they're in a crisis, right? So crisis has a range. I think that's really important, because I think just like my supervisee, that there's this range, right? What crisis means to one person is not going to mean to another. The Chinese language contains two characters, which when you put them together actually kind of nicely describe the concept of crisis. The first character is we, W-E-I, which indicates a critical or dangerous situation. So yes, suicide is absolutely a critical or dangerous situation, or it can be, but so could this idea that, you know, you're away from your children because you're in treatment, right? You've gone to a 28-day treatment center. Somebody else is taking care of your kids while you're taking care of yourself. And that can create some hypersensitivity to things going on in your life that could make you feel that there's a crisis, right? So it's going to have this range. I just really want to make that clear that crisis doesn't necessarily mean lethal, right? Doesn't mean homicide or suicide, right? It certainly can include that. It does include that, but it also has all different kinds of levels to it. So the second Chinese character is Ji, which means an opportunity for change. So really interestingly, taking these two characters and putting them together indicate that crisis is actually a point in time that allows the opportunity to change. So the elements are, there's usually some sense of danger, and then you add to it this opportunity to change how you're seeing this danger, how you're handling this danger, what kind of behaviors you could do around this danger, and or what you don't have, right? What skills you don't have and that we might have to incorporate to help our clients through the crisis. Crisis intervention generally involves three components. First, you have to have a crisis, right? So let's go back to, we have a client who's in a 28-day treatment program for their substance use. And let's say they're doing a phone call home to the family to check in on things. They're new to the 28-day program, so maybe they're just in their first week. They get their first call home to the family to check on their children, to check how things are going. And while they're on the call, it's about 7:30 at night, and they hear from one of their children that they still haven't had dinner. And when your client is home with the children eat dinner at 5:30. So your client is starting to perceive that perhaps her children aren't being fed, right? Because now it's 2 hours later. Why haven't they eaten? What's going on there? Why aren't the people who are watching her children following the schedule that was set for the children while she's in treatment? So there's there's a lot of elements going on to that, but there is this perception from the client that there's an unmanageable situation, right? She can't just jump in the car, drive to the house, and see why the children haven't been fed at 7:30. She's in a treatment facility. She can't leave. All she can do is connect through phone and see and find out that the children haven't eaten at the time that they're supposed to eat. Because she might lack a little bit of power, right? Power, because she can't leave, she can't go and check in on the situation. Her mind start to kind of go? What's happening? Why haven't they eaten? Are they not eating? Is food coming? Are they hungry? Did they eat a late lunch and that's why they're having a later dinner, right? She just has all these things probably running through her mind, but because there might be this sense of powerlessness, because she's not there to check on her children to see what's going on, she might start to believe that a crisis or an unmanageable situation is occurring. The other component to a crisis intervention is the person or the group of people in crisis. So in our case, the individual would be the person who's in treatment. And then it's the helper, the addiction professional, the mental health worker who provides aid to the individual in crisis. Crisis intervention typically requires that the person who's experiencing the crisis receive timely and skillful support to help cope with their situation before future physical or emotional deterioration occurs. So there's if somebody was just walking by, a staff person walking by, and let's say they saw the client on the phone receiving this information, their face maybe starts to frown a little, the eyebrows start to invert, and their teeth start to, kind of grind together a little bit. They start pacing back and forth. Maybe they start wringing their hands. These are all types of just nonverbal signs that perhaps something's going on. This person is experiencing some kind of discomfort. That would be an indication to you, like, hang around. Don't just walk by and be like, oh, looks like that person's having a hard day or they're having a hard phone call. No, that, if you see that, you would be like, maybe I should stay close just to see what's happening, right? Because this person might be entering into a crisis. Let me just see how this plays out, but I'm going to stay close in case it does escalate to a crisis level and I do need to intervene in a timely fashion and offer skillful support. And we're going to talk about what skillful support actually looks like. How do we help our clients cope through the crisis situation so that they don't continue to deteriorate either physically or emotionally? So we'll get there in just a second. So there you have just the three components to keep in mind. You have to have a crisis, a person who's in crisis, and somebody who's going to help the person in crisis through the crisis. And most importantly, it is vital that the staff person performs crisis support in a timely and a skillful way. And we're going to talk about that. So Kaplan and Smead have a good definition of a crisis, and we're also going to talk about what the core function and global criteria definition is for crisis, but I wanted to offer sort of a different lens to this. So here's one definition of a crisis, which I think is really good. It says a crisis may occur when an individual is unable to deal effectively with stressful changes in the environment. So let's go back to our example of a person in treatment, a mother, she's new into treatment, right? It's only been a week. She's making a phone call home and she hears information that her children have not eaten yet and it's 7:30 when they typically eat at 5:30. Now, the stressful event alone doesn't constitute a crisis. So just hearing that information that perhaps her children haven't eaten yet and it's 7:30, 2 hours later, that's not necessarily what's constituting the crisis. Rather, the crisis is determined by the individual's view of the event and their response to it. So I was sort of leading you down this path that, she's making this call home, she's getting this information, and it's not the information per se that's constituting the crisis. It's now that the individual in treatment is escalating what could be happening at home, right? So now she's like, why haven't they eaten for 2 hours? Are they not providing food? How often has this happened? Are my children in danger? If they haven't eaten and it's 7:30, what other critical things aren't happening at that house. The powerlessness. I wish I could just get out of here and go drive down there and check and see what's happening. So that kind of escalation of emotions and not knowing the information and not being able to just go home and check on the children can start to escalate a person into crisis, right? Because they're blowing it out of proportion, right? They might be. We actually don't know. Our children could be in danger. We don't know that yet. But the view of the event and how they're responding to it, and the responding is her ruminating over it, right? So if the individual sees this event as significant and threatening and has exhausted all of her usual coping strategies without effect. Now, this is interesting because if you currently work in the profession, how many of our clients have coping strategies? All of them, right? All of our clients have coping strategies. It's usually, though, their coping strategy is to use alcohol or other drugs, or they're maladaptive, right? Our clients typically do not have great coping strategies. So we need to remember that if we're going to try and help them through their addiction and enter into sobriety and recovery, we have to start teaching them adaptive coping strategies, right? Don't run to alcohol, don't run to drugs. Let's try other things. But you have to remember with our example, our woman is 1 week into treatment. So are her coping strategies really going to be top notch? Are they going to be solid in strength? And even if she did know maybe a few coping strategies, how effective is she with them, right? We have to watch that because she might have learned a few things during her week in treatment. But you and I know you can learn something in a day, but it's the practice that's most important, right? We all know, for example, that deep breathing is a coping strategy to help us relax, right, and stay grounded. But if we aren't practicing deep breathing on a continuous level, we tend to sort of throw out new coping strategies and go and run to our old coping strategies, whether they're effective or not, right? We go to what we know. So if a woman is in treatment for 1 week, I'm going to kind of watch and see, like, what kind of coping strategies does she have at this point? And it looks like right now, from what we have in this example, her coping strategies are kind of just these nonverbal, stressful, behavioral indicators. So nothing that's real effective at this point that, I'm seeing. Also, the individual is unaware or unable to pursue other alternatives. Well, our client is in treatment and she doesn't want to leave treatment. She doesn't know how else, she could actually go and check up on the situation that she believes is escalating towards crisis. And then the precipitating event may push the individual towards psychological disequilibrium or a state of crisis. So the crisis can start to ruminate, the thoughts just kind of going wild because she doesn't have the information. She can't start to stay calm. She starts escalating and things are sort of out of whack. And I think this disequilibrium is a really great piece to explore in the definition of crisis. So disequilibrium obviously is this, state of inequity, right, or equilibrium, where for our example, this woman's emotions are definitely heightened. And if any of you know a little bit about Marsha Linehan's DBT concepts, when the emotional side of you or an individual rises, the logic will default, right? It will go down. It will actually lower. So you're in this state of disequilibrium where emotions are up high and logic is down low. And the goal of DBT is often to raise the logic so that the emotions start to come down, and you keep raising logic until the emotions come down and they meet at an equal level. This is where I always want people to see my hands, because I do like I think about a seesaw, right? And I think about how you want people with both approximately equal weight so that you can do the ups and downs pretty easily, right? But if you have one person who's really heavy and one person who's really light, it's going to stay in disequilibrium. Same thing with somebody's mental health or how they're psychologically working through a state of crisis. So a psychological disequilibrium can be characterized by feelings of anxiety. That's very, very common in our clients. So in our example, our young lady was wringing her hands, she was pacing, she was grinding the teeth, her face was frowning. Those are all indicators that if you're the staff person walking by and you see these behavioral indicators, it could be a good sign of anxiety, right? Helplessness, right? Our lady in treatment is absolutely 100% feeling helplessness because she's in treatment. She can't just leave treatment, go and check on the situation and come back. That's just not how it works. So she has put, right, her trust into other people to help take care of her children while she takes care of herself. And when she gets information that they're not being cared for the way she would care for them, there's certainly this helplessness or maybe even this powerlessness, right? And that is a huge indicator of crisis. Fear, right? And again, some of those anxiety behavioral symptoms can also be indicators of fear. Inadequacy, right? This feeling like I can't do anything, I can't help, I'm not good at this, right? A good mother would be home with her children right now, and here I am not there taking care of them. Confusion. What do I do? What's going on? How come I can't get a straight answer? You know, right, like I was saying earlier in the example, did they eat later? And that's why they're having, a later lunch, and that's why they're having a later dinner. You know, you can't think straight, right? There's this confusion. Agitation, again, sort of that pacing back and forth while she's on the phone, the wringing of the hands, and disorganization. Can't kind of collect your thoughts. You can't, logically line things up. Ella Brock says, crisis at this point, the individual experiencing that disequilibrium, think about our example of the woman in treatment, she may be most receptive to outside assistance, thus providing an opportunity for behavioral change and a return to balance. So, to summarize, a crisis results from a person's negative perception of a situation. So, I mean, this is really interesting because, you know, we're such a society of think positive, think positive, think positive. And there's a lot to that, obviously. But when you've sort of lived a life where things have been hard and the world hasn't always been kind to you, perhaps you've even experienced some trauma in your life, which a lot of our clients, by the way, have. So we have to take that into consideration. um, it tends to be easy for our clients to go to this negative side, right? And think the worst of a situation. So I guess what I'm trying to say is our clients are highly susceptible to crisis. And that's why when my supervisee said, well, you know, I've never worked with a client who's suicidal, and we talked a little more, and I, pushed her a little bit on what's the definition of crisis. She said, oh, well, if you take that away, all my clients are always in crisis. And I'm like, yeah, right. Our clients in substance treatment, a lot of them, a majority, I'm going to go out on a ledge and say 99% of our clients typically are in some form of crisis until we can start to teach them better coping skills and how to sort of work through perceptions of a situation. So we have to remember and take sensitivity to the fact that a lot of our clients, it's a little, they've had experiences that make it a little easier for them to see the negative of a situation, and that will easily escalate them into crisis. Your goals, right? So as a helper, in whatever role that is, right? You could be milieu staff that just kind of like hangs out with the clients. You could be a counselor who does clinical work. You could be a recovery support worker that helps clients work on their recovery plans. Whatever it is, whatever your role is as helping our clients, your primary goals in a crisis are to identify, right? So identify what the crisis is, assess, right? What happened? How did this come to be? What are some of the facts here? What are we going to do? And intervene, right? Get involved, right? So in this example with our young lady in treatment, I had told you that a staff worker was walking by and they started to see the wringing of the hands, the pacing, all of those identifiers that there's possibly a situation. Have that person stay, hang around, right? Wherever the phone might be, don't get right up in their business, give them some privacy, but stay within listening shot, right? So, earshot, and kind of listen. How are things escalating? How are they managing themselves? Does this client seem to be handling it? Do they seem to be sort of escalating and getting worse? Is that disequilibrium occurring? And then your goal is to return the individual to their prior level of functioning as quickly as possible. We already talked about doing this in a timely fashion, and to lessen any negative impact on future mental health, right? We don't want things to get worse. Sometimes during this process, new skills and coping mechanisms are required, resulting in change. So I'm going to say here at this point, can you teach new skills and coping mechanisms to somebody if you don't know any coping mechanisms or new skills yourself? Of course not, right? You have to have what I call, your sort of medical toolbox, right? And that toolbox is going to have a variety of different things in it. But one thing your clinical toolbox or your recovery support toolbox should have in it is coping mechanisms. And this is why I like DBT. And if you're interested, try and take a class or get yourself trained in it or read up a little bit on it. But it has some really good coping mechanisms that you can use with clients to help that disequilibrium. But there are also some, just outside of DBT, things like, and we're going to talk about these in a little bit, but deep breathing, right? That's one thing. You've got to try and get the person to breathe, right? And try and relax just a little bit. And then you can introduce other coping mechanisms. And we'll talk about those in a minute, so I don't want to jump the gun. That's how change occurs. So identification. Identification recognizes that the problem exists, and it focuses on one, the event's significance in the person's environment. So how is this event of the person in treatment learning about their children not eating at 7:30 at night? How is that event significant for the client in their environment? And then how is the person's current functioning? And we can tell at this point, all we know is we have some nonverbals. We don't know a lot, but we can see that the nonverbals are sort of escalating, showing us that perhaps there's an issue. The event or crisis may be characterized as either developmental or situational. So let's take a look at what developmental or situational means. Developmental crises are usually things like, a good example is adolescents and teenagers, right? They have, it's predictable change. You know that because of normal growth and development, there's going to be developmental crisis for our teenagers, right? You know that hormones are going, you know that they're trying to fit into their bodies are changing. Those are developmental things. You know, you could probably think of a ton of examples, but I guess I think back to being a teenager and, you know, what was happening to my body when I first started to develop breasts or I started to menstruate, right? I mean, those are big deals in a woman's life, right? In a young girl's life. That's a developmental crisis. Oh my God, you know, my body is changing. Now, how do I manage, right? How do I play sports now that I have a period, or how do I play sports when I'm developing breasts, right? How does all that work? Because it's different from playing sports as a little kid, right? So that might be a developmental crisis for somebody, but it's predictable, right? We know this stuff is going to come. A situational crisis can be predictable, arising from certain events, maybe a divorce or a failing grade, but they also can be unpredictable, such as accidental death or a natural disaster. So situational crises has this unknown. We're not sure. It could be predictable, it could not be predictable. What we have to remember is no matter what, both types of crises involve a change in circumstances. And let's face it, I mean, I'm going to be honest and say I don't think anybody likes change. I think some of us manage change a little bit better than others. But from my experience, my clients in substance use treatment typically despise change. They don't like it because they don't typically have a lot of tools to manage the change. So, of course, they're not going to like it, right? Even as a functioning person, and a change comes up in my life, I'm always like, ugh, right? Like, oh man, right? And I have my little fit at first, and then I'm like, okay, how am I going to manage it? I'm going to use my tools and I'm going to work through this. Well, that's like a high functioning person who has a lot of support and a lot of tools in her toolbox. Think about a person who's not quite high functioning. They're feeling sick. They're suffering with the disease of addiction. They're isolated and away from their family and friends. And they don't have a clinical toolbox filled with coping strategies. That can really be difficult for someone to deal with. And change usually is accompanied by a loss, and that can precipitate a crisis reaction in a person. That makes sense. And hopefully it makes sense to you too when you start to think about just you in your life when something happens and it's different. I often think about when I had my first daughter, and it was such a joyous, right, event. It was like, yes, we have a new baby coming into the world. This is so great. But even though it was happy, it changed our lives, right? It turned our house upside down. It changed everything my husband and I did together. We could no longer just go out to eat at 9 o'clock at night if we wanted to, right? Our lives were turned upside down. And that's change. And that's also loss, right? We lost some of our singlehood, some of our freedom once our daughter came into our lives. We had to change how we did things, and we certainly changed how we looked at things. So even though it was a happy change, it 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 precipitated sort of a crisis reaction in us, like, oh my God, what are we doing? And how did we get here? And what are we going to do now that we're here? Right. So, I mean, that's sort of a big example, but you have to think about it in terms of your own life. What kind of changes have come into your life? How have you handled them? And, what kind of coping skills did you need to tap into? And how did you first respond? Right? When the crisis first happened, how did you first respond? And, think about that in terms of when you're working with your clients, right? You can't just be like, oh, God, come on now, calm down. Because telling someone to calm down helps them calm down never, right? That is not a good coping strategy. So, you need to really try and tap into that empathy when you think about how you handle change in your life. Physical changes that may occur, some physical symptoms, people's overall health, their energy level, right? They might actually be more lethargic than usual. They might, their activity level might change. Eating and sleeping patterns, they might start to eat more or eat less than they usually do. They might start to sleep more or sleep less than they used to. And these are all indicators that there might be a problem, right? Something might be going on. They're not managing something in their life in a healthy way. So you got to pay attention to people, right? And that's what I was kind of trying to get at with the staff worker when I was saying that the staff worker needs to kind of hang out, check out the situation. You got to know your clients. You got to know, right? You got to know what a typical sleeping pattern is for your client, right? All of our clients are different. Not all of them sleep 8 hours, and we can count on that, right? Some are typical 6-hour sleepers. Some are typical 9-hour sleepers. Some of them typically don't eat a lot. Some of them, are constantly sort of grazing and eating. So you can't just, look at something that, oh, that person's not eating a lot, that there must be, a crisis happening. So you got to sort of look at the big picture. You got to look at this whole holistically. And so you would take into account physical changes as well as psychological changes. And emotional signs, right? Are you starting to see this increased tension or fatigue? Any changes in temperament where a person who's typically pretty calm and happy-go-lucky is starting to have these anger outbursts or really feeling depression? And I think this is a good place to mention that depression definitely can look different in our clients, right? Not all clients are going to have symptoms of depression like crying and sadness and, sleeping too much or too little or eating too much or too little. We have to remember that men typically express depression differently than women express depression. So I think that's really important to sort of mention and be aware of when you're watching your clients and you're looking at them and you're seeing how they're doing. Men will typically tend to show outward behaviors of aggression or anger when they're feeling depressed, and women will tend to sort of express inwardly with, maybe crying or sleeping too much or eating too much, that kind of stuff. Other behavioral signs include an inability to concentrate, being preoccupied with certain ideas, or social withdrawal, right? Those might be indications that a person is in crisis. Again, look at this, like, is this out of the ordinary? Does my client typically have a hard time concentrating? When they're in group, they're sort of all over the place, or they're doodling on a pad. They're looking all over the room and they're chit-chatting with the person next to them, right? If your client is always like that and you see it, you can't necessarily assume that they're in crisis, right? But if your client is typically, able to concentrate, sit still in group, get their assignments done and all that kind of stuff on time, then, you start to see these other behaviors, then you might think, okay, inability to concentrate, what's going on there? And again, you can't assume that it's crisis. There might be other things going on like ADHD, right? Who knows? Being preoccupied with certain ideas, right? This preoccupation is a big thing. And again, don't isolate it to just one symptom, right? If you see that one sign, it's not necessarily leading to crisis. Assessment was one of the steps that Ella Brock talked about. So once you've identified the crisis situation and the person who is in crisis, workers, that's you, assess the crisis's impact on the individual. How's this individual being impacted by the crisis? This assessment usually takes the form of an interview where you talk to them. I know that sounds like a crazy idea, but that's what we do, right? So in our example with the young woman, the worker sees all these behavioral symptoms and psychological symptoms and emotional symptoms and says, you know what, I think this is getting to the level of crisis. I'm going to move in a little bit closer. And when the telephone call is done, I'm going to, pull her aside and I'm going to ask her, is she okay? Is there any way that I can support her, etc. So the assessment usually takes the form of an interview during which the worker strives to convey an atmosphere of acceptance, support, and calm confidence about the future. So acceptance, right? I'm here for you. I see what's going on. Can we talk about it? How are you doing? What kind of support can I offer you? Um, Perhaps I could teach you some coping skills to work through some of the feelings that you're having now so that if anything comes up in the future, you can certainly use these again. Communication with the person experiencing a crisis is vital, right? Get in there, have that conversation. I have supervised staff members before who really feel uncomfortable working with clients in crisis, right? They feel like they don't know what to say. They feel like they're going to make things worse. Um, and I have to say, well, what if you get in there and you make things better, right? Like have some confidence. So the more confident you feel about crisis intervention, that you can go in, you can talk to the client, you can stay calm yourself and not get sucked into the crisis, that you can teach crisis intervention and coping skills, that is going to make you more comfortable approaching clients that are in crisis. Um, establishing eye contact is always important, right? Because that's telling that person, I'm here, I'm connected, right? I'm listening, and you're my priority right now. Nothing else is going on. I'm stopping everything else to be here with you. Sometimes physical contact is appropriate, but again, you need to be kind of careful with that because you don't know if there's a trauma history. If the person's really agitated and you reach out to them, their response might be to push you, right? To push you back, and you could get hurt. So you really need to kind of feel it out, know the client. You can even ask sometimes, like, is it okay for, me to put my hand right here? Is it okay for me to guide you to the couch so we could sit down? So we're going to talk about this in a little bit, but how you are responding, right? You're going to be mirroring your behavior onto the client. So if you're coming in all agitated and nervous and scared, well, the client's going to mirror your response. They're going to get agitated and scared too. But if you come in and you're calm, your voice is gentle, you're making that eye contact and you're being genuine, you're showing empathy, and you're just really showing genuine concern, then typically that client will mirror that and start to actually calm down a little bit. So it's going to be really important for you to maintain, your calmness and your centeredness or groundedness. Assessment. So you're going to have questions addressed to the individual. Could be things like, how do you see this problem? Right? So the client is concerned about the children not having been fed by 7:30 at night when they typically eat at 5:30. How does the client see that? What's their perception of this problem? Do they believe that the children aren't being cared for properly, right? Because how we think about that problem doesn't matter. It's how our clients are perceiving it, because we have to get into how the client sees it, the frequency and sequence of events, his or her feelings, and a history of attempts to deal with the problem. So has this problem come up before? How often has this happened? Is this the first time you're dealing with this? How do you feel about it? And typically when you've had these feelings before, how did you deal with the problem? Forced choice or open-ended questions may be used to assess the individual's ability to communicate. Sometimes our clients are so worked up, they're not going to be able to give us a lot of information. We might have to start with sort of these close-ended questions like, can you hear my voice right now? Right? Are you comfortable sitting on this couch with me? Can we talk? Right? So those are just yes or no's, but that just starts, it's enough to get the person talking, but it doesn't overwhelm them. Because sometimes our clients might respond with like, it's too much. You're asking me too many questions. I can't think, right? Remember that confusion piece. And as they start to sort of calm down and come back from the disequilibrium, we can start to ask open-ended questions like, tell me how you feel about this. What kind of feelings are coming up for you? And sometimes our clients cannot identify feelings. It's actually fairly common for clients to know about 3 to 4 feeling words, and typically angry, happy, sad, maybe even fearful. Right? But it's really hard sometimes for them to expand beyond those 3 or 4 feelings. So sometimes we might have to ask them again with these sort of forced choice questions like, are you feeling, scared? Are you feeling powerless? Right? Are you feeling out of control? Right? How are you feeling? Right? And the more you can get them to relax, the more you might be able to get them to respond with more open-ended questions like, tell me about what the phone call said. How did it go? Tell me about it. I covered that. Assessment may include what the individual is saying as well as their nonverbal. So I gave you a lot of nonverbals in our example today because all you could hear what was going on the phone, but what was probably most important with that is what was the facial expression. So in our case, she was sort of frowning. The eyebrows were going inverted. Her posture, she was pacing, wringing her hands was the mannerisms, right? So grinding of the teeth. So an essential part is taking not only what you're hearing, but also what you're seeing. And this is pretty common with, you ask a client, how you doing? Right? And they'll say, oh, I'm fine. Right? But their face is clenched and their hands are clenched and their shoulders are up near their ears. They're not fine, right? But perhaps they're not ready to talk. Perhaps they just don't have the trust with you yet, or something. You got to find another way in. So very important to take nonverbal and match it with the verbal. An essential part of assessment is the evaluation of the person's current safety, as well as any risk to his or her own or someone else's life. And over my years of working with people in treatment centers, I've certainly seen a variety of people's responses to crisis events. I've certainly seen people throw furniture across a room. I've seen people attack other people. And I've seen people sort of, go to self-harm measures when in crisis. So you have to be able to assess that risk level of that person harming themselves, somebody else, or potentially hurting someone else. I know the young woman who threw the chair in a treatment center just was angry and needed to exert energy and just picked up the chair and threw it. I don't think she intentionally meant to throw that chair and hit somebody and hurt them. And luckily, in my example, nobody did get hurt, but that it was more just an energy. So you have to sort of, maybe if someone's in crisis, they're very agitated, clear the other clients out of the room, right? And try and get this person, somewhere safe where other people can't get hurt and they can't get hurt. Additionally, you got to assess factors such as alcohol and drug use, current stress level, emotional affect, such as hopelessness and helplessness, and those should all be identified. And I think we've talked about that, right? I mean, you're looking at this person's level of hope, right? How hopeless do they feel? How helpless do they feel? I think in our example, our young lady feels pretty helpless right now. I don't know that at this point we know enough to say she's hopeless, but she certainly feels like, I can't get there to check on this situation, and that leaves her feeling a little helpless. Her current stress level is obviously pretty high from her nonverbals. Interventions. So a lot of specialists in intervention work, they might differ on the name and number of steps involved, but they all tend to mostly agree that certain points are integral to intervention and are basic to a best practice problem-solving approach. So I took this from Hoff and Greenstone because I just thought, we have to kind of narrow this down for you. We have to say that there's a certain number of steps or, a certain best practice to intervention. So it might look different with different authors, different interventionists, but this is pretty much the general theme. So first, while supporting and empathizing with the individual in crisis, the worker should listen and definitely avoid phrases like, I understand, so as to allow the individual full and open expression of feelings and emotions. Do you really understand? Right? When you're listening to somebody, and you're responding with things like, oh yeah, I understand. Do you really, right? Can you really understand somebody unless you've walked a mile in their shoes? So something better might, say, what I hear you saying is, right? That might be a more appropriate way, and actually just like a clearer way to express that you're understanding what's happening in the situation, but try and avoid that I understand. Second, the individual in crisis should answer the worker's questions so as to define and clarify the incident and acknowledge any social or cultural factors which may relate to the crisis. The second step places the problem in a framework. As Burak states, understanding of and respect for the differences inherent in each culture are needed for rapid, effective, and sensitive treatment of emergency situations. So again, right, making sure you're tapping into sort of that cultural and social piece and get that information so that you understand it. Don't just assume that you know it. Third, the worker develops an awareness of the significance of the crisis from the individual's point of view. I know I've talked about this already, but it's really important to stress that it's not how you would see the situation. It's not like, geez, it's only 7:30. I'm sure the kids are fine. You don't want to say things like that because from the individual's point of view, it's 2 hours past their dinner time, and perhaps it goes deeper that she's not fully trustworthy of the people watching her children, and that's creating a lot of anxiety for her. These first three steps may have been partly completed during the identification and assessment stages of the crisis. It's important they're finished before going forward to the fourth step. Fourth, mutual brainstorming of alternatives and discussion of available resources are jointly carried out by the individual in crisis and the worker, right? How you're going to do, what the plan is, needs to be carried out by both of you. What is the client going to do? What are you as the worker going to do? At this point, the worker may need to be more directive, right? Focusing on the current situation, proposing ideas and strategies for action, as well as suggesting other resources for support instead of just listening and reflecting, right? So give some tangible ideas, right? This is what we can do for this situation. And we'll talk about those in a minute. Fifth, the individual in crisis and the worker choose one or more specific, time-limited goals, which take into account the person's significant others, social network, culture, and lifestyle. Complete planning, including recognition of all the steps involved, as well as consideration of any barriers to success. Brief education, modeling, role-playing, rehearsal of potential situations can be done in this step. Right, so in our situation, perhaps, we role model and work out with the client, we role play what they could have said on the phone to get more information about why the children haven't eaten at 7:30 at night. 6, the worker and individual implement their plan, they put it into effect. 7th, the worker provides for follow-up or referrals. So if the client in crisis is not your client, please make sure that you're following up with their counselor or following up with someone that they work with closely. So in summary, crisis intervention provides the opportunity and mechanisms for change to those who are experiencing that psychological disequilibrium or who are feeling overwhelmed by their current situation, who have exhausted their skills for coping, and who are experiencing personal discomfort. Crisis intervention is a process by which a substance use disorder worker identifies, assesses, and intervenes with the individual in crisis as to restore balance, that equilibrium, and reduce the effects of the crisis in their life. The individual is then connected with a resource network to reinforce the change. Thus, as the Chinese characters we talked about in the first slide, crisis truly holds the opportunity for change. Time for a discussion question. When talking to a client in crisis, use the phrase, "I understand," as often as possible to show that you're listening. False, right? We do not do that. We say more appropriate things is what I hear you saying is this. Now, I did promise you we were going to talk a little bit about the IC&RC definition because that's what you'll be tested on. So the first part is really a lot about you just getting this more global concept of crisis intervention, but the IC&RC definition is what you need to know for LADC examination. And the IC&RC, according to Herdman, defines crisis intervention as those services which respond to an alcohol and other drug abuser's needs during acute emotional and or physical distress. See how brief and compact that is? That's why I wanted to give you a broader definition in the beginning. But a crisis is defined as any significant event during the treatment process that threatens to jeopardize or destroy the treatment effort. Crises have many causes. They may or not be related to AOD use. And in our example, it wasn't AOD. The global criteria, so what you need to know how to do during crisis intervention, is recognize the elements of the client's crisis, implement an immediate course of action appropriate to the crisis, and enhance overall treatment by utilizing crisis events. I see this as so compact of a definition. That's why I wanted to really expand upon that in the beginning. Determination of a crisis, and we've already talked about a lot of these, so but I wanted to give you Herdman's definition of this. Our clients are definitely going to be subject to abnormalities in perception. They're going to see things differently. So I talked about this when we talked about it being a little bit easier for them to see negatively versus positively based on life's experiences. It's going to be compounded if they have a co-occurring mental illness. A client's misperceptions can create an exaggerated sense of urgency for the client, right? We have to remember that if they're misperceiving something, they might think, I need to leave treatment right now and go and check on those kids, right? And that might not be the case. This might be able to be worked through without this drastic response of leaving treatment. And it can lead to mental or emotional confusion we've talked about. Check the validity of the crisis, right? Understand and have compassion toward the client's unique reaction to the precipitating event. Precipitating event may not be the actual cause of the crisis. So what we're understanding is that the kids haven't eaten. They usually eat at 5:30. It's now 7:30. They still haven't eaten. But what's really underneath some of that, right? Is there this fear that the client isn't there taking care of her own children? Does she not have a lot of trust and faith in the people that are taking care of her children? What's actually kind of going on, right? Assess the seriousness of the crisis. We've talked about that, right? What's the elements of the crisis? The process, counselors should resolve or diminish the crisis while using it as a therapeutic opportunity. We talked about that. Relate the current situation to a past experience where the client was successful in resolving something similar. And our clients might not always have that, but if you can, definitely. Was there another time where you had really heightened anxiety? How did you work through that? Then the client can recall their own strengths, tap into their clinical tool bag like we talked about. And crisis intervention is really a form of brief therapy. You engage the client, you work with them to identify the situation causing the crisis and help them to move beyond. Counselor limitations, and this really is for any worker, really. It doesn't have to be a counselor, but know that you're competent and trained in handling this. If you aren't trained or competent, then consult people that you work with, right? Get help on the situation, get trained, go to your supervisor. Be familiar with the resources in your community. Who in your community might be able to help out with this situation? Understand your protocols and policies at the ER, the emergency department, psychiatric hospital admissions, detoxes, shelters, food banks. 12-step meetings. During a crisis, when a client is not emotionally stable, the counselor must be prepared to take action to protect people. During irrational times, clients might want to hurt those who are trying to help them. I think we already kind of covered that. Crisis prevention is always preferable to crisis intervention, and that's really teaching clients coping mechanisms right from the get-go, but also just being alert to any mood changes, behavioral changes, or attitudinal changes. Like, is something brewing? Trauma is certainly something that can easily set off a crisis if they have a traumatic background. 4 types of traumas that can set off crisis. We've talked about situational, developmental, and there's another one called intrapsychic, and that's when your thoughts and feelings can lead to crisis. And also existential, and this is from Herdman. Reactions to crisis. People can feel shock, anxiety, depression, anger. They can intellectualize, really like cut off from their feelings and just sort of live in their head. We all know those kinds of people. They might have this need to flee, and certainly this acting out. The goals for crisis intervention are the same ones that we have covered: stabilize, relieve the pressure as much as possible, convert the emergency to something solvable, and return the person to their current functioning. Process of crisis intervention: establish rapport, gather relevant data, assess the risk of danger, determine whether medical intervention is needed, what is the client's ability to cope, investigate what support networks you'll need or the client will need, develop a plan of treatment, and follow up within 24 hours. I think we've covered a lot of that. Be careful when you're working in crisis intervention not to take responsibility for the client, right? Don't give false assurances. Don't say everything's going to be great, don't worry about it, because you don't know that. Don't become anxious yourself. Don't focus on problems, focus on solutions, and don't project your own interpretation of the crisis. The better the prognosis, if the sooner the person gets help, the better the prognosis. Herdman says 10 to 14 days is the average length of time people struggle with a crisis before seeking help. Discussion question: counselor danger zones include taking too much responsibility for clients. True. Absolutely. We just talked about that. We've talked about the qualities of an effective crisis counselor: having empathy, being able to ask appropriate questions, assessing things quickly, knowing your limits, having boundaries, and making use of good resources. We've talked about the signs of depression as well, but here they are. And here's just more statistics for you. Populations at greatest risk for suicide, clues to suicidal potential, right? Definitely depression, desire to kill oneself, confused thinking, inability to cope, all these kinds of things. All threats always have to be taken seriously, no matter what. Some quick coping strategies: mindfulness and meditation, grounding are good things. So deep breathing is always a really good one. And a grounding exercise that's pretty cool is asking your client when they're sort of, in disequilibrium, asking them to identify 5 things that they see, then identify 4 things that they can touch, 3 things they can hear, 2 things they can smell or like to smell, and 1 thing they can taste. We talked about breathing exercises, but I've given you just a quick breathing video you can check out, box breathing. And that is the end of the presentation. So again, thank you for joining me on this hour of crisis intervention. I hope it gave you a good sort of global perspective on the skill of crisis intervention. If you have any questions, please feel free to email me. Thank you and have a great day.